بسم الله الرحمن الرحيم. السلام عليكم. أنا محمد ضفاء الله، اختصاص الباطنية والغدد الصماء. Welcome to the Clerkship series. Today we have another case which hopefully has several learning points that will be useful for you during your clinical or clerkship rotations and in your clinical practice in the future, inshallah. So let's go on to the case. So this is a patient with the chief complaint is witness seizure. So the history of presenting illness, this is a 20-year-old police cadet أو طالب شرطة. He's brought to the emergency room after his colleagues witnessed him having a seizure episode. So they note that while they were preparing for an afternoon class, he informed them that he doesn't feel well. He then collapsed to the ground and began shaking vigorously. And this lasted for about 1 minute and then it resolved. So there was a small amount of blood coming from his nose, and but he did not have any urinary incontinence. He was then quickly transported to the barracks clinic because he was not responding to his colleagues. So ودوه العيادة في السكن because he was not responding. His bunkmate noted that he reports the patient having high fevers and reported neck pain the day before presentation, but he did not seek medical attention. فده زميله قال إنه عنده patient كان يشتكي من neck pain وفيفر لكن ما مشى له طبيب. So there, the review of systems was difficult to obtain because the patient is not alert. Of course, you can take a review of system from the witnesses, but you get whatever information you can from the witnesses to help you make a diagnosis, and that's what you need to do. You need to reach a diagnosis. So in his past medical history, also difficult or unable to obtain because he's not alert. But there were records that were brought from the police academy with the patient, and the notes says he does not have any known medical condition, that he was healthy. Usually الناس اللي بيخشوا أكاديميات الشرطة والجيش بيعملوهم full physical examination and full history, and they should be generally healthy and fit. So family history is unable to obtain also. And social history, his colleagues report that he is a social smoker. So يعني he بيدخن only socially. So maybe when he has a party or some, with friends who are smoking, he might smoke, but otherwise he's not a chronic smoker. So this is a question. Or several questions rather. So what do you expect in his neurological examination? And what's your differential diagnosis? And what pertinent information should you inquire from the patient's medical record? فهم جابوا لك medical record. What information would you like to obtain from this medical record? So pause the video, think about the answers to these questions, and then resume the video to find out the correct answers. Okay, so in his physical examination, vital signs, blood pressure is normal, 110/63 millimeter mercury. His heart rate is 102. He's tachycardic. Respiratory rate is 18, and his temperature is 38.1 Celsius. So he's febrile. So generally, he is difficult to arouse. He has perspiration in his forehead, HEENT. There is no evidence of facial or head trauma. The neck is rigid to movement, so there is some resistance to movement of the neck, but there is no lymphadenopathy in the neck. Chest examination he has normal vesicular breath sounds bilaterally. The rest of the chest examination is normal. When you get this in the exam, لو في الامتحان مثلا جابوا لك مثلا examination of the chest ذكروا لك حاجة وباقي الحاجات ما ذكروها, assume that they are normal. Don't assume that there is some pathology with them if they are not included. The examiner usually does not like to waste ink. ما بحبوا يضيعوا حبر في الامتحان. فإذا ذكروا لك معلومة أكيد مهمة, وإذا ما ذكروها إذا don't worry about it. يعني ما تحاول تفكر إنه يا ربي يكون عنده حاجة تانية ولا كده. Okay. So cardiovascular exam, the apex is at the 5th intercostal space, mid-clavicular line. He has a normal S1 and S2, no added sounds or murmurs. His abdomen is muscular, there is no rigidity or rebound, and there is normal active bowel sounds. We didn't talk about abdominal tenderness because he is not alert. So, but there's no rigidity or rebound. Musculoskeletal and skin, there is no evidence of trauma or skin lesions noted. No purpura seen. Okay. CNS, Glasgow Coma Scale is 10 out of 15. So when you calculate the GSC, the Glasgow Coma Scale, you look at several things, which is eye response. So his eye response is 2, verbal response is 3, and his motor response is 5. So I want you to go back and review the Glasgow Coma Scale and what these mean and how we came up with these numbers. Okay. في الكلينيكال براكتس لما تكون براكتسنج حتى لما تكون في الكيسز تشوف patients يتعود انه to break down the GCS تكتب انه what the eye response was, verbal response was, and motor response. Don't just write whatever number out of 15. Okay, get in the habit of writing it out عشان تتعود انه how to do a GCS correctly and how to calculate it. عشان مرات لو الزول اخطأ في رقم هنا حسبها غلط بعد ذاك ممكن يطلعوا الصحيح. So cranial nerve, motor and sensory aspects were difficult to assess because his altered mental status. Kernig's and Brudzinski sign were negative. Okay. Okay, so differential diagnosis includes meningitis or meningoencephalitis because the patient has fever, nuchal pain or neck pain, and seizure. Okay, so seizure can occur in about 5 or 10% of patients with meningitis. You don't always need to have Kernig's and Brudzinski sign. These are positive in about maybe 10% to 15% of patients with meningitis. So they're not يعني هم ما diagnose ما دائما موجودات. They're not pathognomonic, but they can occur in patients with meningitis. Okay. So you should inquire about vaccinations and history of complement deficiency or asplenia from the medical records. فإذا في الميديكال ريكوردز خاطين الفاكسينيشن هيستوري ومفروض انه الميديكال اقصد الميليتري ريكروتس البوليس ريكروتس مفروض يعملوا لهم فاكسينيشن خصوصا ضد النسيريا مننجيتيز عشان لانه هم بيكونوا في كلوز كوارترز مع الناس التانيين حتى الناس اللي بيمشوا الحج برضه بيعملوا لهم النسيريا مننجيتيز فاكسين. history of complement deficiency هو قالوا ما عنده history بتاع أي other medical conditions لكن إذا عنده أي history بتاع recurrent infections or something like that maybe he has a complement deficiency. If he had any trauma وحصل له يعني removal spleen, this can be important. They frequently get gonococcal infections, Neisseria meningitis, and other infections recurrently. So less likely differentials are epilepsy. So إذا هو عنده recurrent seizures بيسموها epilepsy, but you can put it in the differential diagnosis لكن it's not necessarily the correct diagnosis. Most likely he has meningitis. He can have a primary brain tumor. Primary meaning إنه هو يعني السورس الأساسا البرين. And this is more common in younger patients. إذا كان older ممكن نقول metastasis. Metastasis is more common in older patients. But in younger patients, primary brain tumors are more common. It can also be drug intoxication. And believe me, when you see a younger patient, think of drug intoxication commonly. It does happen, even if he's a police cadet. You will be surprised at how people get their hands on drugs and alcohol. So a question. So what investigations would you like to request to aid in making the correct diagnosis? So pause the video, think about what investigations you would like to obtain, and then resume the video to get the correct answer. Okay, so let's see what investigations were done. So he had a CBC with differential, a blood glucose, electrolytes, renal function tests, including total protein. You should get blood cultures ×2, so 2 vials of blood for blood culture, a blood film for malaria. هنا لأنه نحن عندنا في السودان it's endemic, so you should get a BFFM. Maybe he has cerebral malaria. So you should get a toxicology screen if it's available, and a non-contrast head CT to see if there is any um, brain pathologies, such as a brain tumor or a space-occupying lesion. Also, you should get it before doing a lumbar puncture. And you should measure the opening pressure with the lumbar puncture. So أول ما تدخل النيدل طوالي بتقيس ال opening pressure. Okay? But you should do the lumbar puncture after you rule out a space occupying lesion in the brain with a CT. عشان كده بتعمل a non contrast head CT أول. Okay. uh, in the lumbar puncture or the CSF you should get WBCs, glucose, تعمل gram stain, تعمل culture, bacterial culture, تعمل protein وتعمل viral screen. These are the more basic things. You can do extra things if they are pertinent, لكن basic things you should do are these things. Okay. If is a patient عنده more than 2 seizures أو there is you're suspecting انها دي ما seizure اساسا, you can do an EEG. لكن usually it's not very useful. Sometimes بين السيجر والسيجر بتكون an EEG normal. وفي حوالي كم في المية, يعني حوالي 3 ل 4% من الناس ال EEG بتاعهم اساسا فيه features that look like seizure في ال EEG, لكن they're not in seizure. That's just their normal EEG. EEG is not always useful, but it can help you if there is more than 2 seizures, or if you're suspecting that this might not even be a seizure, that this patient may be having pseudo seizure or something like that, or maybe a syncopal episode. Okay, so the treatment, you should aim to treat the underlying cause if it's found, and you should consider long-term anti-epileptic drug treatments in patients for whom the underlying etiology is likely to persist or for prolonged or recurrent seizures. فإذا عارف السبب, هنا مثلا البيشنت بتاعنا most likely عنده meningitis, so we treat the meningitis and his seizures should go away. إذا مثلا في لقيناه for example عنده brain tumor, or you think that maybe it will take some time قبل ما يعالجوا brain tumor, so في الحالة دي تقوم تدي anti epileptic drugs عشان ما يجيه recurrent seizures تانية. اوكي. او اذا patient جاته recurrent seizures, جاته one maybe جاته 3 or 4 seizures, you should consider giving anti-epileptic drugs. Okay. للعيان بتاعنا, so you give stat, meaning very fast, very quickly, emergently you should give antibiotics and corticosteroids after you obtain blood culture. So بتسحب الدم عشان البلود culture, واساسا انت داير تعمل السي بي سي والحاجات دي, ف you take blood quickly and then you give the antibiotics and the corticosteroids. So you give dexamethasone 10 milligrams IV every 6 hours. The first dose should be with ceftriaxone and vancomycin every 12 hours. So في الامتحان غالبا في الكلارشيب ما حيسألوك من الدوسجز, لكن حيسألوك من يا تو antibiotics حتختار as empiric therapy, meaning علاجات قبل ما انت تجيك النتيجه بتاعت اللمبر بانكشر جرام ستين او الكلتشر او غيرها, لكن امبيريكلي بتغطي معظم الحاجات اللي حتعمل لك بكتيريال مننجايتس. فهنا هتدي سيفتراياكسون وفانكومايسين. اذا العيان عنده مثلا عمره كبير مثلا, شاكي انه يكون تجيه ليستيريا, ليستيريا مونوسايتوجينيز, بتدي معاها امبيسيلين. فكده you choose the antibiotics based on the most likely organisms that might cause the meningitis. Okay. dexamethasone عشان لأنه بقلل لك inflammation of the meninges والcomplications بتكون less. لكن you should give the first dose with the first dose of the antibiotic. Okay. So this is another case. انت قاعد في المستشفى في اثناء ما بتعالج في العيان الثاني, so you are covering the medical ward evening shift, انت قاعد بالمساء, والنيرس اتصلت عليك وقالت لك she witnessed one of the patients having a seizure which lasted for about 3 minutes. فهي عملت finger stick glucose, اتأكد من البلد شوجر لقيته 88. لما انت بس ما وصلت, the patient again developed a seizure 10 minutes later. Okay, so she had a second seizure. So هنا, what is the most likely diagnosis? What is the diagnosis هنا? And how should you manage this condition? So pause the video and think about this. It's something that is very important to treat emergently. Okay, So pause the video and think about the answer before proceeding forward. Okay, so the diagnosis هنا status epilepticus. ليه قلنا status epilepticus? Because if there is more than a seizure that's more than 5 minutes of duration, so more than 5 minutes of continuous seizure activity, or more than or equal to two seizures, two discrete seizures, يعني كل واحدة على حدة, without complete recovery of consciousness in between. So هنا they didn't tell you that the patient recovered, but you within this time frame is the patient did not wake up, then you consider it status epilepticus. How should you manage it? أول شيء تبدأ بالA B C. الايرواي مانجمنت قد تحتاج تعمل intubation اذا البيشنت عنده continuous seizures عشان to protect the airway عشان ما يحصل له aspiration. Then you look at the breathing. You might need to give oxygen or put the patient on a mechanical ventilation device. And then you look at the circulation. You should obtain an IV access immediately. إذا ما بتقدر to get an IV access, some medications you can give IM لكن continue to try to get an IV access. Okay? And then you give dextrose if the blood sugar is low. إذا العيان أنت شاكي إنه يكون عنده thiamine deficiency بتدي الثيامين قبال الدextrose. Okay? So بتدي thiamine وبعديه dextrose. Okay? And then you administer anti-epileptic drugs. Okay, you transfer the patient to the ICU and you should do EEG monitoring, continuous EEG monitoring. Yes, this is not available everywhere, لكن if you have it تستعمل EEG monitoring continuously عشان تتأكد إنه إذا البيشنت ما if they're not shaking or يعني seizure activity is not visible to the eye, you can monitor the in EEG you can tell you if the patient is still in seizure or not. Okay. So this is a treatment algorithm of how you would give the anti-epileptic drugs. First, like we said, an airway or breathing or circulation, you get some laboratory tests, you get IV, you give them IV thiamine, بعديه dextrose. If they are continuously seizing ممكن تديهم short acting benzodiazepine زي اللورازيبام. الديازيبام برضه short acting لكن it has a longer duration it has a longer half life. So it starts to work quickly لكن الهاف لايف بتاعتها طويلة شديد. فإذا أنت مثلا في كل 10 دقائق اديتهم دوز it will just stack up. Okay, so lorazepam الجسم بيتخلص منه سريع. Sometimes it's not available everywhere. The other option is midazolam 10 milligrams IM. اللورازيبام ما I don't think إنه فيه IM formulation, but I'm not sure of that. But midazolam it has a IM formulation. If this doesn't work, the patient is still in seizure, you can give another dose. If the patient is still in seizure, you can then give phenytoin or fosphenytoin, and you should write it as fosphenytoin. You write the dose مثلا 20 milligram per kilogram. Phenytoin equivalents, you have to write this out. Okay? عشان لأنه إذا حصل أي لخبطة وقام ادوا العيان phenytoin rather than fosphenytoin, إذا زول قراها غلط قرا بس كلمة الفينيتوين وقام اداه الدوس ده، يعني هنا لاحظ انه بدوه 50 ملغ per minute، هنا 150 ملغ per minute. فاذا العيان ادوه من الفينيتوين more than that كده هيعملوه overdose and it's gonna be a problem. You have to write PE, this phenytoin equivalent. Okay. If this doesn't work, then you can put them on a midazolam infusion or propofol infusion. If it still doesn't work, maybe you can give phenobarbital infusion. Okay. هنا في bypass هنا مثلا إذا ما عندك الفينيتوين or fesfenitoin, you can give valproic acid or phenobarbital or levetiracetam. Okay. You don't have to memorize this. You don't have to memorize it. لكن know that you can give medications in sequence. Okay. And this is the end of this lesson. I hope it was useful. Please go and learn about the different seizure causes and how to manage each one, and also review the Glasgow Coma Scale. Okay. Also, you can also review the management of meningitis, both viral meningitis and bacterial meningitis. Okay. Good luck and thank you for listening.